this computer. Okay, hello. Welcome. Let's see if I can get rid of my picture. Nope, that didn't do it. Hang on one second. We're not going to stop sharing. We're going to start sharing. There I am. Or no longer. No, I'm not here. You guys didn't want to see my mug. Um, oh, yes, 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 yes. Okay, guys, welcome. This is Pain Seminar 2, coming to you guys from Grace Midcity, where we are trying to uh, get off the ground a pain support group that becomes something self-sustaining and truly is just something that's needed in the Baton Rouge community. So, one of the things that we thought about, and me as a clinician and who really kind of is fully immersed in pain science, is we thought that taking into account that one of the best modalities for managing pain is better understanding pain. So we started the first 4 weeks, and this is week 2, is doing our pain support groups with a little bit of an introduction and a little bit of like hot topics in pain science as sort of a launch pad for discussion in the support group, but also just as like good learning and understanding a little bit about your body. So welcome back here to week 2. That's me again. That's my bio. I found that when I started doing like speaking events, and when I used to be in the audience and I would like hear some presenter for the first time and somebody would like read their bio. And I was just like, wow, how awesome are these people? And then when I started speaking, you write your own bios. So then I was like, oh, these people are just writing their own stuff. Anyway, so I always thought that that was really interesting. So now I tell them, don't even recite my bio. I'm just going to kind of do my own little thing. Here's me in a nutshell. But the most important thing is that I have become very involved and immersed in pain science and in helping patients to better understand what their pain experience means as a means to help them control or manage or regulate that pain experience, among many other things. So that's a little bit about me. What I wanted to do also each week, I want to kind of do a little review and recap of what we talked about in the previous weeks, just to kind of so that when we introduce some of the topics here, if they reference anything from the weeks before, now you kind of have an idea. I will always start with this. Generally, any presentation I'm giving around pain, whether it's to a layperson, a patient, or other clinicians, we're starting with this, and it's the fact that when you really understand your pain experience automatically gets better. So it's this old adage in the mental health community, this name it to tame it, right? When we can put into words those things that we're feeling within us that are very terrifying, they become easier to manage, they become less threatening. So I love this quote. Again, this is one of my go-to books, Explain Pain. The two writers are Lorimer Moseley and David Butler, two just excellent pain clinicians out there. And they say the physiology of pain can be easily understood by men and women in the street, so any layperson out there. And understanding pain physiology changes the way people think about pain, reduces its threat value, and improves the management of it. This is kind of that high level research that we mentioned last week to show you that in a world of like the medical model really gravitates towards evidence-based practice, this is what I use to show other clinicians that the evidence is there for this. And, you know, I earlier this week gave a presentation about pain science to some physical therapy students. And I don't know if y'all follow different like news things. I think Blake and I might have talked about this, but the New York Times put out an article maybe about 6 months ago. And it basically said something to the effect of what works for your back pain comma, nothing, study says. And I thought that just like how devastating to read this, right? And it's such a like, we're in a clickbait world. We see a title like that, you know, and not just New York Times put this out, but then all of the like news channels did their 3-minute blurbs on it, right? And had their medical analysts like, well, you could try this, this, and this. And the reason that this was kind of upsetting and off-putting is that they did not look at pain neuroscience education for chronic low back pain. The other thing that they didn't do is and what we haven't done historically, because we continue to think about it all in this one frame of reference as all low back pain is the same. And then we looked at like, well, does exercise help? Does manual therapy help? Does this type of manual therapy help? Does, you know, nothing help? And not one of those studies included pain neuroscience education. And so also, when you look at something like chronic low back pain, and we talked a little bit, or we'll talk actually this week about the different classifications of pain. Chronic low back pain fits into this category of it's not about your tissue. It is about your central nervous system. It is no longer reflective of what is happening here, but rather that nociceptive pathway that we introduced last week, that sensory processing pathway gets really ramped up, and that alarm goes off way more. Okay. And so for us to try tissue techniques on people presenting with a chronic pain issue, it's never going to work, right? And so of course the research is not going to show that it works. But that was a really devastating moment for pain clinicians to say, okay, can we not say stuff like that, right? Can we not say stuff like that to a chronic low back pain population who is already suffering? They're already in despair because their needs are not met, right? And then you just kind of salted that wound. So anyway, sorry for getting off on a tangent. Here is our 4-part presentation. Remember last week or our first pain seminar, we talked about sort of the basics of the nervous system and sensory processing. This idea that everything we experience in our life comes in the form of sensation. And we take that message into our nervous system and it shoots up to the brain, and the brain decides, is this important? Is this a threat? Do we need to do something about it? And then it does, or it doesn't. This time we're going to go into the 3 different classifications of pain. So what we kind of used to call acute pain versus chronic pain has now become 3 different buckets. And I think what is important about understanding this, both as a patient in pain and as a clinician treating pain, is that it matters to know which bucket your patient fits in. Now, sometimes we fit into all of the buckets, but the most important thing is when you can really hone in on the specifics of why a person is feeling what they're feeling, then we can treat it better, right? So an example I give is like, if a patient comes in and their tissue, they present objectively to me with like a myofascial, they're in spasm, they have trigger points, they have all of this stuff, but I don't pick up on a lot of inflammation. And the medication that the physician has offered them is an anti-inflammatory, or an anti-inflammatory injection, or an ESI, right? An epidural steroid injection, or all of these things that are tried, and then they don't work, right? And they don't work because we're treating inflammation that's not actually there, right? We're assuming that this is an inflammatory thing when it's truly more of a myofascial or a spasm thing, or giving someone a muscle relaxer and assuming it's going to help with an inflammation thing. So it becomes really important for us to be able to understand which bucket that person is fitting in. Okay, so a quick review of what we sort of went through last week. We talked about this idea that when it comes to managing our own pain or managing our own stress or any of those things, it all goes back to your nervous system and whether or not we are safe and regulated in our body. Because I have clients that have persistent pain, but because they are safe and regulated in their body at a given moment, that pain is not causing suffering to them, right? And then I have other times where they're out of their body. They don't feel safe. They don't feel regulated. They're more stressed about other different things, and they feel much worse, right? So it's this idea that a safe and regulated nervous system is our ticket to being well, regardless of what's happening in our tissue, regardless of what diagnosis we have, all of that stuff. And our pain experience gets better when our nervous system is in a better place. So when my nervous system feels so safe and regulated that I'm picking up on cues in my environment and they're actually accurate, right? So that my nervous system is not assuming that this input that's coming in is a threat when it really isn't. That's also going to help us, right? So what is a regulated nervous system, right? It's not this calm all the time. We're not robots. As humans, we have a nervous system that responds to stressors, okay? The key is that we are able to get back down to a baseline, right? And so the four things we talked about was safety, okay? So safety in our environment. So if we are someone who's got a lot of stressors in different ways, our job is hard, work is a lot, relationships with family is hard, all of those things. And some of those things we can't change, right? We can't walk away from a job. We can't walk away from caregiving to an elderly parent, right? Or I can't walk away from my children. They're stressors sometimes, but how do I create other places of safety in my world that can help balance that system out, right? And if there are danger or unsafe things in my world, let me eliminate those that I can, right? So I give the example sometimes of like, I stopped watching and reading horror and suspense and those sort of things because I recognized that they would add anxiety to me that I did not need to be added to the system, right? That's a silly example, but it is one of those things that it's like, turn off the true crime podcast when you're in a flare up, right? Like it just doesn't need, I'm looking at you, Blake. Wow. We don't need to add to it, right? Okay. The next thing that we need is connection, our ability to do what we're doing in here, to sit and connect and engage socially with other humans who are safe for us, right? And to not engage with the ones that are not safe for us. So to create boundaries and those sort of things. But our nervous system we as humans desire connection, right? Activation. So was it you? We were talking about after that, you were like, I feel good when I'm like moving and doing things, or sometimes when I'm like sitting in the sun and experience. And that's the other thing is that our nervous system, if we don't provide any sort of motivation and input, we're gonna also assume that that's a threat, right? If my body is not moving the way it was designed to, then it's gonna start being like, is something wrong here, right? And then our little threshold goes up, our alarm system starts to kind of go off. And then lastly is rest. We have to, adequate sleep, adequate rest, adequate quiet time, self-reflection, all of those things. So the other thing that we talked about was sensory processing, and that is kind of what I just described, this idea that everything in our world and we as humans, how we thrive, how we survive, how we have evolved, is that we have been able to pick up on cues in our environment and respond to them productively, right? And so what sensory processing looks like, and it's sort of the baseline for what our pain experience is that we take some sensory experience, whether it is something external in our environment. So last week we used the example of we walk outside, it's a little bit colder, we walk back in, grab a coat, or my body creates chill bumps or anything to kind of raise my core temperature on its own. But that sensory input comes in, the message gets sent to the nervous system. Generally, the messages are very unbiased. It's just a blanket statement of like, hey, you just been touched on the outside of your arm, or hey, this temperature it's a little bit different than we expected, or whatever it is. It's just a very kind of benign statement. It's the brain that makes the decision about whether or not it's important. And this is happening millions of times, and it never really reaches our consciousness unless the brain concludes that it's important enough to make us think twice about it, to make us move, to make us do something, right? So sensory in, that message is processed and the brain generates some sort of response. Sometimes that response is pain. If the brain interprets that some sensory input coming in is a threat or a danger, he's going to let us know. We're going to start limping. We're going to prop that leg up. We're going to ice it. We're going to wrap it. We're going to do the things that we know socially to take care of ourselves. I'm going to get to the hospital if it's a snake bite and not a twig. I gave that example last week as well. The goal is always safety and survival. So, right, many, many years ago, it used to be that we were attacked by a saber-toothed tiger. Fast forward to now is my back pain has been here for so long, and it is now my personal threat. It is now my personal stressor that I think about constantly. It ramps up my nervous system all the time, right? And so the goal that the brain has is, how do I make her aware of this so that we can get back to safety, right? So that's why we end up in this place of persistent pain, is that the brain's like, don't you need to know about this? Don't you need to know about this, right? It's like a dog with a bone, the brain. Okay, so let's talk about the different classifications of how we define pain. So right off the bat, what I love about including this in my presentations, and this is the IASP definition of pain, the International Association for the Study of Pain, all the big gurus in one meeting room. But it says pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. What I like about this is that not only is it a sensory sensation, right? It's not only something that we feel in our body, in our tissue, it's also emotional, right? That's a huge piece. And when we show you the different buckets, that emotional piece gets way bigger when we start talking about persistent pain, or what we call nociplastic pain. The other interesting thing that I want to always point out is that it also says potential tissue damage. So the fact that actual true tissue damage does not even have to be present for us to have pain. If my brain perceives something potentially dangerous, it can elicit the same thing. So it's not even that its pain is a true or direct reflection of what's happening in the tissue. It's just its interpretation of what's happening in the tissue, right? So I think I use the example of, like, you know, how can we quantify that there's someone sitting in the ER with like a arrow or like a nail through their head, and they're not feeling that, right? They're sitting there, you're like, that has to be very serious. But for whatever reason, they're not alert to it. They're not. Or we have the person with persistent pain and all the images show you're fine, what's going on. Or I love the example, there's like the example of the construction worker with the whether it's the nail gun or like some shard of thing falls through his boot, right? And he looks down and he sees it pierce through the boot. It's coming out the bottom, and he's writhing in pain, and he gets rushed to the emergency room. In the emergency room, they're like, don't take the boot off, we'll do images. And images show it's not even through his foot. It's like between his toes, right? But the look, visually, right? The vision is part of our sensory input. The vision tells us, like, that's not really good, right? I can see that is not a good situation. And he's in pain. There's nothing there. There's no tissue damage. I also gave the example of like the soldier who did not even realize he had a limb blown off, because in that moment, the number one thing was for him to get to safety, right? He didn't even realize how much pain he was in until he woke up in the safe zone, right? And so this is what sort of those complex layers of pain is, that it's not always that clear, This is the other thing, is the evolution of what we understand about pain. We've gotten to this point of the biopsychosocial model of pain. And some people would even argue that this is still limited because it doesn't include the spiritual component or the energy. I see an energy worker who is part of my healing team, right? And this thought that there is even more than this that goes into who we are and what we feel at any moment. But this is about the best we have right now. And the number one thing is that it's no longer just about the biology of what's happening in the tissue. We have got to account for this person, how they grew up, their belief system, their religion, their economic status, whatever it is that plays into their assumptions about pain and their own mental and emotional health and lability at any moment, right? So those are other factors that affect how we feel at any given moment, okay? It's not only about the tissue. So these are the three different categories of pain. I put this graphic in there to where if anybody's ever going back and listening, if anybody's out there listening, you can get back to this image and look at it if you like. But here are the three categories or the three buckets of pain. We have nociceptive pain and what we kind of used to call acute pain. Then we have nociplastic pain, which is kind of what we used to call chronic pain or central sensitization. Sometimes we use the word persistent pain now, which I think is a little bit better than chronic pain. Chronic tends to account for like a length of time. And what I have found is that a person can enter into the nociplastic bucket in a very short period of time versus it needing to be like, oh, it's got to be 12 weeks or 12 months that they're in pain for it to be called this, right? It's not about a time thing. It's about that. How ramped up did my nervous system get and how protective did it get in a short amount of time, right? The final bucket is neuropathic pain. And we're going to kind of go through each of these. So this is a big fancy definition that IASP came up with. It's a lot of words. Don't get too caught up on it. The number one take-home message is, if you recall from last week, if anybody watched that video, when we talked about the nociceptive pathway, that was the sensory processing of a noxious stimulus. What this means is that we have sensory receptors in our tissue that if a threshold is reached for a sensation, so if it's temperature, if a high temperature or a low temperature is reached, or if it's a pressure mechanoreceptor, if an intense enough stimulus is produced, it triggers this nociceptive pathway, which is a different pathway from just kind of the normal benign sensory experience. It doesn't always end in the experience of pain, again, unless the brain decides this is important and this is a potential danger and threat. But I wanted to kind of circle back to that because you might see that word nociceptive and remember it from last week. We used to call it acute pain, but it is an experience based in our tissue. What I mean by that is that when we have an injury and we have an inflammatory response after that injury, the chemicals in the inflammation will trigger a nociceptive pathway and those sort of things. But pain is often associated with true or localized tissue damage. It's usually sudden and sharp. And generally, once the tissue heals, it goes down. It kind of follows this little graph, which I think I have in a minute. So nociceptive pain is what we kind of consider that acute pain following an injury. And then once we're healed, it should be gone, right? As a clinician, this bucket fits all of the objective measures that we learn. So if we measure range of motion with our little goniometer, or we measure muscle strength, that's reflective of a tissue being well or not well, or some sort of dysfunction. But that doesn't help me when I look at nociplastic pain or persistent pain, okay? This is also why an image may be helpful in this situation. Imaging is not going to be helpful to us in the nociplastic bucket because nothing is usually found on the images, okay? So what I love to point out with this little pie, chart, which, you can ignore acute pain and chronic pain, is that yes, while there's a good portion of this that is reflective of the tissue, it still always has the psychosocial components too. So as a clinician, even if I'm treating someone with this in this bucket, I'm still talking to them about their mental health. I'm still teaching them about pain. I'm still talking to them about all the factors in their life right now and how we can eliminate some of the ones that are threats and danger and how we can boost some of the ones that are more safety. because that always matters, regardless of the tissue. And this is like, I think what makes me a little bit different as a clinician is my lens is always the nervous system. Yes, I will treat tissue. Blake can account for that because I can dig in to a trigger point. I treat tissue, but always with the undercurrent of I'm also adding in things that are nervous system generated. Like I'm wanting to also do things that are calming to the nervous system. No one would argue that a good trigger point release is calming to the nervous system. So I have to balance it out with a little zhuzhing. Okay. The second bucket is nociplastic pain. Again, lots of words right there. The take-home message for nociplastic pain is that it is no longer reflective of what's happening in the tissue. What it is actually happening is that nociceptive pathway that we learned about last week, from everything from the sensory receptors to the nerve that carries to the spinal cord, to the nerve that carries up to the brain, all of those aspects become sensitized. What that means is we start making more receptors so that message gets sent quicker. The nerves that carry it, we also make more of those so that they're more robust. The reason we do this is that the brain starts to pick up on, she's not paying attention to this. They're not getting the message. They're not behaving. So I'm going to make them hear this more and more and more. And we do that by generating that nociceptive pathway by making it way louder, way stronger. The problem with that is it starts picking up on benign things that are not actually problematic, that are not. So that threshold that we talked about that has to be reached for the noxious stimulus to trigger the nociceptive pathway, now it comes down. Now we're triggering that pathway with just gentle touch or a little bit of chemicals or a little bit of change in temperature. Now we're super duper reactive to that. So what we call, and we used to use the term central sensitization, but I would argue that it's not just central. It's not just that the brain is now sensitized, the whole pathway is. So it's that our nervous system is now overly sensitized. We could circle back to what we talked about with nervous system regulation and safety. Another way to say this is this nervous system is dysregulated. It is misreading the signals that are coming in, the sensations that are coming in. It's assuming everything's a threat when it actually isn't. Okay. So here's our back to our little pie chart. Is the tissue still problematic? Sometimes it is. Even with my patients with persistent pain, nociplastic pain, they still have trigger points. They still have a little inflammation that I can actually attune to. But again, I'm doing way more of the other stuff. When I used to work in the clinic, in the insurance model, and I tended to get the ones that were like, oh, I can't get this person better. Claire can handle them. And my coworkers used to say, Claire can take a simple knee osteoarthritis and turn it into mommy issues because I would be in the room and we'd be crying, right? And we walk out and they're like, I thought this was just a knee. Like what happened, right? And it is a knee sometimes. It's also mommy issues and other things, right? And also as clinicians, both as a physical therapist, so the range of motion measurements and the manual muscle testing and all of that go out the window because it's not actually truly reflective. These people usually come in and they say, I'm exhausted, I feel weak, my balance is off, all this stuff. And then I'm like muscle testing them and they're strong as an ox. Why? Because their nervous system is so ramped up. They're in a state of fight or flight. They could like lift a car if they needed to, right? And so, but they don't feel that. What they feel is absolutely exhausted, right? And so that's no longer a true reflection and indicator. We have to look at the nervous system. We look at posture, right? People have a look when they're in pain. We look at their gait. We look at muscle length, not in terms of a muscle being like the tissue being tight, but that the nervous system is generating this protective response, right? So, okay, here are a couple of concepts when we look at the nociplastic bucket. The allodynia and hyperalgesia are two things that are basically like allodynia is a stimulus that is so benign across the board. Everyone would agree this is non-threatening, but it's now threatening to that person. And then hyperalgesia is that threshold is just lowered. So now my system is being triggered at a way lower level. So these two things are similar, but it's just that allodynia is like, you're feeling pain if I'm just light touch. If I'm doing anything that should feel fine to anyone, it's producing a very reactive response to you. The other thing is that stress and that mental and emotional psychological component of this, they just precipitate and feed off of each other. If I'm in more pain, I'm feeling way more stressed out. I'm more reactive. I'm angry. I have a short fuse. I cannot engage. I'm not safe. I'm not, and that also makes us puts us in more pain, because the nervous system that regulates both of those responses is the same. It just plays off of each other, right? The other thing I wanted to include, I call is smudging of the homunculus man, the virtual body. So you may not be aware of this, but we have in our cortex, we have sort of a mapping of our body sitting on our brain. And what I mean by that is that if I touch my pointer finger, there's a little part of my brain that if you were looking at my brain with a functional MRI, you'd see like a light pop up. So that aspect is connected to this part of my finger. So we have this mapping of our entire body on our cortex. The problem is when we get into a point where we are sensitized, that whole nociceptive pathway is too much alarm, the crispness of those different areas of our body, we lose that. It starts to smudge. They call it cortical smudging. And what is problematic about that is that what started out as a right SI joint injury has now turned into, I've got pain all the way down, kind of goes. And of course, it's not reflective of like, no, sciatic nerve's fine, and no disc, but now it's all down here. It's also up my back, and sometimes I even feel it in this other. That's what we mean by cortical smudging, is that now we can't even localize where that pain is, right? Because the whole system is like, okay, well, we need to also alert him if he gets some sort of sensation up here, right? So it just grows. So now the whole body becomes sort of sensitized. So that's what we mean by the cortical. This is the picture I was talking about, where if we have some injury, right, and we have the whole healing process, which includes inflammation and scarring and all of that stuff, we're going to get an increase in pain right after injury and when inflammation is real rogue. And then as that tissue heals, this comes back down. That pain level comes back down, right? This is how our body's like, I responded to that stressor. It's gone now. I'm going to come back to baseline. That's how we heal and respond to anything. Here is the top line that you see, the squiggly line, is the nociplastic bucket, which means that regardless of the healing of the tissue, I'm still stuck in this limbo of like, I'm in pain. Something's not right. And it continues to trigger. My brain is like, something's not right, but we can't find what it is. So I'm just going to keep alarming, right? I'm going to keep alerting because we got to find what's wrong. And this is like, we become a dog with a bone. Like, we got to find it. We got to get more images. Maybe that image wasn't good enough. Let's try this image. Like, and we go down trying to find what it is when it's actually the nervous system that's doing this to us, right? The problem is the brain. And the hard thing about that, right? If you talk to any person who has persistent pain, they have been told it's all in your head, or they are so afraid to be told it's all in your head, because I think in the medical system, we have not handled that discussion well. If those physicians are saying something like that to you, maybe they are clued in as, hey, this is a nervous system thing, but they're not sitting and having these sort of talks, right? They're dropping that bomb. They're saying, we're going to call in a mental health practitioner, and you get the message that I'm crazy. Something's wrong with me, that this can't get better, right? And then he thinks I'm crazy, this doctor and that is extremely frustrating. And add that to the cycle of stress and emotions and despair and all of those things, right? So that's it. I like to use this example too when I was a clinician in the clinic. This was like the pain man we handed out. And it's like draw an X where you feel the pain and then rate the level. And so this one on the left was a total hip replacement, post-op hip replacement. She had one little spot, she listened, she put the X, and then she said, sometimes it's a 1 or 2. This is a fibromyalgia patient. I remember both of these individuals actually. This is a perfect example of the smudging of the cortical body, right? There's no X here because there's no X, there's no spot, right? What we feel is all over the place, and it is the worst case scenario. So this is the difference between nociceptive bucket and nociplastic bucket. That's not to say that nociceptive bucket cannot have severe pain sometimes, but it's still very we can find objectively a connection to why that is and where that is, right? But that kind of wandering, thing is really reflective of the nociplastic. The final category is neuropathic pain. And what's interesting about neuropathic pain is that when we talk about like, a ligament that has that pathway that's sending a message to the brain about like, hey, we just got stretched way out of, if we have a sprain, the nervous system itself has the same nerve, like sensory processing network. So if my nerve is getting compressed or it's got inflammation around it, it's picking up on a chemoreceptor, which activates a sensory processing. So the nerves can be damaged just like any other tissue, and it can be sensitized just like any other tissue. So it's a hard concept to think about that, like, oh wait, I thought the nerves were getting the message. They can also be injured, right? So peripheral neuropathy, we have peripheral neuropathy or central neuropathic pain, which would be a spinal cord injury, brain injury, or diseases like multiple sclerosis or those sort of nervous system, diseases and lesions. So peripheral nerve entrapment, it can be compressed, it can be inflamed, it can be actually severed or cut. And the symptoms is usually like the tingling, the numbness, the paresthesia type thing, a shooting pain, that sort of thing is usually connected to a nerve issue. And in central neuropathic pain, the thing that I wanted to include here is that this is probably the hardest thing to treat. I have 2 patients right now, or 2 clients right now who I see who have MS, and they're probably the hardest because they're perpetually, it's a new story every time I see them. Something totally new hurts. This lesion over here is now flared up, so I'm having this symptom versus last week it was this. And sometimes they respond really well to this type of manual therapy. Then the next time that is very provocative. So it can be hard. It's inconsistent. It's unpredictable. It's also why sometimes it can be interchangeable with the nociplastic bucket, because it can, this can be kind of chronic. People live extended periods of time with central nervous system dysfunction. Okay, I think that's all that I wanted to kind of go over. All right. So what we did a little bit last week before we kind of turned this off and chatted a little bit is I wanted to see if there was any questions that you guys had that I might be able to answer that would maybe help. And then we'll kind of peel off into our little discussion. How are we? That was a lot. Are we good?
That was a lot. I'm still having a little bit of trouble.
The different buckets?
Different buckets.
Yes.
Yeah.
It's hard, mainly because why couldn't they come up with words that were different?
Yes.
Right? Can we go back to acute? Can we go back to acute and chronic? That is very hard, and it's sort of like even I get kind of like, no, see, but what was I talking about? So for ease, we can still say acute, chronic, or acute and persistent, or tissue-related pain and nervous system-related pain, right? It doesn't matter. As long as, without too much of the wordiness, we're understanding that those three buckets exist. And I think a huge problem as to why we are in, or we have historically been in a pain epidemic that's led to an opioid epidemic, is that we have been treating everyone as tissue buckets. We get images to look at tissue. We get injections to the tissue. We get medication or creams to the tissue. Everything is tissue treated. And then we're wondering why second bucket isn't getting better, right? And then now we've made them frustrated and we've made ourselves a little bit frustrated. And so that's where we are. And that's kind of what I wanted to, even hone in on, is this is just the recognition of these different things. And a lot of people, you yourself, and, Blake would probably volunteer, that we fit into a couple. Yeah. Where I will say, generally, if you have neuropathic pain, the last thing we talked about, and it's like a peripheral neuropathy, you're also going to have muscle tension. You're also going to have posture dysfunction, movement dysfunction. You're going to have things up the chain. So there's none of these in isolation. But I think the big thing, as from the clinical perspective, is we've got to get very curious about what the patient has if we're actually going to help them with it, right? We cannot treat muscle spasms with an anti-inflammatory, So that's how I'm feeling. We good? All right, we'll talk more. How do you, questions, comment?
It's great to have the descriptions of the buckets, because sometimes too, being in the middle category, where you have the persistent pain, you feel like it's acute, right? Like you're convinced that what you have is right here, but it's not really.
Right. Well, and it's a little bit right there, but it's also, you're feeling it so much because the rest of the system is telling you this is really important, And actually, one of the things that you just said made me think about that middle nociplastic bucket, right? The nervous system driven pain. There's a big piece to associations. This idea that every time, it's got to be my bed, Claire, because every time I sleep, I wake up in pain. And if I sleep on the ground, I don't have pain. So we start connecting, whether or not those associations are actually, I'm sure they do have some credibility and some, but we can create a lot of, it's like the placebo effect or the nocebo effect. We can create a whole narrative that starts becoming our reality based on a thought. And so that's good and bad, right? And I think it's good when we can say, well, every time I sleep in my bed, I hurt, but when I sleep on the ground, I don't. So I'm going to sleep on the ground every night, and maybe you don't have pain, right? And so maybe that association is so true, or you've created such a connection there that now you've found something that actually helps, right? And so I think there's some benefits there. The problem is when we associate this, every time I do this, it hurts, and we get stuck there, then we start becoming very limited in what we can do in our life, right? Yeah. Okay. We're going to stop here and peel into our little group. Uh-huh.
First of all, for pain, I've been ran over twice on a motorcycle. There's other days I've been adrenaline junkie.
Right. Okay.
I myself.
Adrenaline junkie. I have not been run over twice by a motorcycle, so there you go. Okay. Right. Okay. Okay. I'm sorry, an 18-wheeler?
Yeah, the trailer. The trailer smacked me on the side while I was getting in the turn lane, and they decided they needed the same turn lane.
Oh, okay.
Well, point I'm getting at is to speak about the sleeping and what works.
Right.
Believe it or not, the best sleep I've ever gotten was on 20 sacks of oysters. My dad's an oyster boat captain. Yeah, so oysters, so are very sharp.
Oh, yeah.
Not ideal.
Not an ideal bed situation.
But believe it or not, when I laid down on that, maybe it was because it was after a hard day of work.
Yeah.
They hit the right pressure points. I'm not sure.
Yeah.
But I woke up so refreshed.
And we talked last week in a similar way about like you go and sit in the sun, and there's something about that for you that is just like you're going to feel better, right? That's like that's a perfect nervous system safety, that you can like do any day it's sunny. That's going to give you something good. I may have mentioned this last time because it reminds me of this. There's a book called The Gift of Pain, and the guy who writes about it was talking about that when he would have back pain, that chronic low back pain, and when he got into a flare up, kind of almost like the gate theory, he would go outside and walk barefoot in like gravel, and there was something about that stimulus that it was almost like a gating, right?
Yeah.
Because the stimulus, he had control over it. Like, it's not fun to walk on rocks, but he felt like this was something that he could do that would dampen his back pain, right? And so I think it's a very similar thing too, where like, maybe those sacks just hit the right little corners and stuff. I'll do this too, that sometimes, my big thing is I'm a manual therapist. You can see I have cup marks right now. And every now and again, my arms will flare up a little bit. And of course, it sends me into a tizzy because these are my money makers. These are my magic tools. And it like something about my bed or the way so like I can get in the bed with one of my children who, mind you, have worse mattresses than I do. And then I'm like, no, I'm good now. Is there anything like, is it the fact that this tiny human that I had a part in creating who knows, right?
That mat that you can lay on that has all.
Oh yeah, the acupressure.
Like,
Yeah.
kind of distracting, but like it feels good whenever you're laying on it. It hurts, but in a good way. But maybe it is distracting from.
It hurts, but not the suffering hurt that you not that hurt that has been destroying my life for however long. Okay, I'm going to stop us. Thanks for tuning in.
I'm gonna tune in next week because